And may I now take the pleasure of inviting another doyen of research in surgical gastroenterology in India, Professor R.A. Sastry. He's a very revered teacher and a researcher. He will be talking about prospective interventional trials and studies in India, problems and solutions.
Yeah, after Dr. Kate's talk, I think this will pale into insignificance. This is more of a problems-oriented presentation. Why a prospective interventional trials in India are not so common? What are the problems? And do we have any solution for this? We all talk of evidence-based medicine, and all of us tend to believe that we always follow evidence in our practice, but the evidence itself is otherwise. In one study, level 1 evidence was practiced by surgeons only by 24% of them. We do acknowledge that quality and quantity of RCTs in surgical practice is limited, leading to rhetorics as this, even in reputed journals. A look at the clinical trial registry in 2 periods, as analyzed by Pramesh and Dhananjay Sharma, I've partly modified it, has not shown much change over a period of time. Surgery and surgical specialties account only for, say, 1 to 3% of all trials, whereas the interventional trials occupy about half of them. It's a consolation probably that GI surgery does have a significant role, significant proportion of trials in the total number of trials. What are the issues pertaining to conducting a surgical trial? Dr. Agarwal was referring to some of them just now. Now, let me go through some of them in the next few minutes. What is our general perspective of an RCT? As a surgeon, we think it is difficult. We think it is impractical to undertake in surgery. We think it cannot be generalized because of high variability of a surgical procedure. And we think skill, experience, and judgment affect outcomes. And we know that surgical volume improves the outcomes, and volume doesn't come unless you start practicing. So you cannot have a trial before you get those volumes. Expectations from surgery, unlike, say, from medical options of treatment, are more. Surgery is considered the last resort of a condition. And the surgeon also holds a personal responsibility for the outcome. It's also a fact that unlike the medicines which need to go through phases of clinical trial, a surgical procedure does not have to go through a trial basis. So let me go through some of these. Say historically, validation of surgery is rarely practiced. Many of the current operations were introduced well before RCTs became established. And once a treatment is established, testing it against a placebo may be even considered unethical by some people. The temptation to ignore evidence that threatens personal interest and commercial interest holds high in our reluctance to practice, undertake any trials. This is amply distributed by the laparoscopic cholecystectomy in a consensus conference in 1994. Even when increased bile duct injuries was acknowledged, but the consensus declared that further RCTs are neither feasible nor necessary because the technique is so widespread. Equipoise is difficult to obtain because of bias. You practice something, you are emotionally attached to that procedure, you think that procedure is the best. So the personal bias from a surgeon and from a patient point of view too. A patient, he would look at, say you have a trial of minimally invasive surgery and an open surgery. He would definitely prefer a minimally invasive surgery. There is a lack of equipoise from a patient side too, and this would lead to a bias in the study and difficulties in blinding. Inability to discern between efficacy and effectiveness. Both aim at, see, what good is coming out of your practice of this particular procedure in an ideal situation when it is efficacy, in a practical day-to-day situation when it is effectiveness. You concentrate on effectiveness, whereas a clinical trial would require efficacy. Surgical techniques are difficult to standardize because they are complex. You have multiple components of a complex long surgery, like in GI surgery, which is difficult to standardize. Funding is a problem for many of the surgical trials, interventional trials. You do get a sponsorship for a trial which involves a new instrument or a disposable, but when you're comparing two procedures or a procedure against a placebo or a sham operation, it's difficult to get funding. Lack of knowledge of statistics and epidemiology is the other obstacle. There are other technical problems too. The learning curve in a surgical procedure is long. And there is no clear definition of an operation, and even the learning curve, when exactly you've reached the end of it, is difficult to decide. When you have a trial of two operations, it's very difficult to define each operation and the components of it. And then the quality control monitoring of not only the quality of the procedure, but the quality of outcomes is difficult. Procedural variations are common, so is RCT required for every single modification? Deciding on when an RCT is required for an intervention is itself difficult. The other factors which would come into play are the surgical training structure itself, which is apprentice-based. Although it is changing thanks to the availability of knowledge, still we tend to do what our boss did. And our bosses, of course, they are changing. They always found what evidence is acceptable to them. They did have some dogmatic approaches, and which still prevail. Some people even think that it's an affront to your independence. Who is he to say? I have done hundreds of operations. Who is he to say that the modification is necessary or this is not right? And the attitudes of some of the surgeons. We don't believe the study because we can remember a situation in which X or Y was more useful. So you tend to believe in what was most recently your experience. Interventions are used because the surgeon is worried. That is a difficult operation, to give 2 more days of antibiotics or leave the drain for a few more days. So breaches of protocol are common. And then the other barriers are, see, you people from cities do not understand our problems is a very common thing you hear in conferences. The difficulty, the inability to discern what is best, thinking that latest is best, and what starts as a multidisciplinary, what should have been a multidisciplinary care becomes a clash between disciplines. And you have equal or equivocal results from 2 different modalities, an endoscopic and a surgical. And then bias would be there, and thinking that aggressive treatment is the best treatment. So how exactly you have, what kind of comparators you have when you plan a surgical intervention study? It could be a a surgical technique against a sham or a placebo, or between two similar procedures, not too much difference, or a substantially different surgical procedures, or surgery versus no surgery. This I have partly modified from this study. And what are the challenges when you have this kind of comparators? Sham surgery is very, very difficult to get an informed consent. Who will agree that, say, there is a surgery which has some benefit and you may be included in a no surgery? Similar surgical procedures, say a D1 versus D2 gastrectomy, substantially different, say open from a minimally invasive, and a non-surgical versus surgery, a stent versus, say, a phrase in chronic pancreatitis. Of all these, you find that comparing two similar surgical procedures is the most practical. These become difficult. It's not that they don't have solutions. The complexity of surgical intervention is depicted here. So the possible solutions. Now the historical part, constant data collection. You have a good evidence base to indicate areas of warranting new trials of old procedures. If only you have a good database to base your clinical question, your research questions, and challenge an established procedure. A commercial competition becomes less obstructive if there is a continuous and comprehensive performance evaluation, which is easier said than done. Very difficult in an egocentric surgical community. Surgeons equipoise, how do you get that? Include a parallel non-randomized preference arm alongside an RCT. But then the number is a big hindrance for us. And you have some numbers which go into this parallel arm, then you will have difficulty in getting numbers. Funding, a culture of cooperation rather than competition, facilitating large multi-center and multidisciplinary groups. And when you have that, that would attract funding than when you do as an individual. Learning curve, evaluate the curve by its appropriate statistical technique and show the completion of the curve before randomization. The other way, which is not really tested, is to randomize to the surgeons and not to the operations. And then the operation, you define and break it into components. The components can be quite detailed, and each step you have a clear definition, and it is not that impossible to have the definition. Quality monitoring is, of course, important in precise photographs, videos, and pathological specimens. The question is, again, is RCT all? Do we need RCTs for everything which we practice? RCT may be preceded by a preliminary phase studies, like you do in drugs. That would develop satisfactory definition criteria for procedure, test measures for surgical quality, define endpoints, sample size, and analyze the learning curves. So you have a preliminary study before you undertake an RCT. The other sources of evidence, prospective non-randomized evidence, as I was thinking, and a meta-analysis of non-randomized evidences. So it's important to decide whether you really require an RCT for a given intervention. This is an example of how you can break a procedure into its components. It's a very simple thing, but it can be extended to even complex surgeries. So I conclude, say the validation of surgery by RCT is historically weak. We acknowledge that. And there are special difficulties, historical, structural, and cultural. And the solutions are attention to issues of learning curve, detailed definition of intervention and its components, and quality control, a preliminary non-randomized phase, and integration of modified RCTs with prospective audit and quality control studies, which should be a part of your working as a surgeon. And you have a prospective audit, you build enough database, and you would know where you want to do an RCT. So these are the few ideas which I wanted to share. Thank you for your attention.
Thank you very much, sir. Do we have any questions from the floor? I'm sure there must be many problems and practical difficulties in conducting research. You may please come up. Yes, I think many of these questions were covered with the last talk. Yeah.
I have a gut feeling that each and every patient of hernia doesn't require mesh. What type of study I can do?
Dr. Vikram, I think you would be the best person to say what kind of study you would require, mesh versus no mesh.
No, for every case, like a simple
So you'll have to qualify, you have to
adult
decide
inguinal hernia unilateral. So whether the mesh has to be put in or not to be, because earlier we used to do hernia without any mesh and the results were satisfactory. But I want to
Dr.
have an evidence.
Dr. Khandelwal, can I just come, just make an observation? There's a group called an abdominal wall repair group, and they carried out an assessment. How would you have your inguinal hernias done very recently? And the surprising thing was there was a huge amount that opted for open, a largish amount for tap, and a largish amount for tip. But it was very surprising that a lot of them opted for open. So that, that is what Professor Sastry was trying to say.
It was not open versus minimal invasive. It was mesh versus no mesh.
Well, even that it has to be an RCT. If you want to have a scientific proof of whether you really want a mesh or not, it has to be an RCT with and without a mesh.
Sir, I think it can be answered in a patient population with bilateral hernias. We were the first one to publish in surgical endoscopy, putting lightweight mesh on one side and traditional mesh on other side in same patient. So I'm not sure whether it is required, because now evidence is that putting in a mesh reduces recurrences by 20% more in inguinal hernias. If you leave out shoulders,
So
because
unethical you want.
no, but surgery has to be reproducible. All the idea of evidence-based surgery is reproducibility. Shoulders may be good in his clinic, in his hands, but can we reproduce that?
So
That is the question.
let's try and concentrate on the research methodology rather than on one subject. Do we have any other questions? Yeah, yes, sir, please.
I think with experience you learn, like if it is a very small umbilical hernia and if it is a comorbid old patient, I will always do open. And my juniors will keep on pushing me to do a laparoscopic one. I do laparoscopic surgery, but in few selective patient, I will do open. So it is all about your experience, and it all depends on what is the comorbidity of the patient and how old the patient is, how big the hernia is. So it's your clinical experience. I would say.
You do wonderful laparoscopy, I have seen it. But there is evidence that any hernia with area less than 4 square centimeters, and needs no mesh, anatomical, yeah.
For umbilical, it is less than 1 centimeter diameter.
The area, 4 square
Area is
centimeters.
4, but for umbilical, it is 1. But then, that's about one surgery.
Again,
Yeah.
it's only an expert
That's why I
opinion.
said
It
common
only
sense.
amounts to an expert
So,
opinion.
what do you think is the way ahead for India, for our younger postgraduates?
Our young
Because
postgraduates-
in the light of two things, we have a lot of resource in terms of the patient population that we have, heterogeneity, of course, lots of procedures, and we can contribute significantly to the science. So, what is the way ahead?
See, the first thing is to have a robust database of whatever you're doing. That is most important. And from that, you can decide on, see, RCTs are fine, but we know the problems with RCTs for an intervention. See, how many interventions, RCTs we know of, except D1, D2 gastrectomy and a handful of them. So it's not always necessary. But when you have enough database, even a retrospective study of a cohort study would give you enough idea of, whether to do an RCT or not do an RCT, and then you, based on the results of that, you proceed. So, but for that you need to have, one, a robust database, two, a mindset to improve. See, am I doing enough? Is there something else? No, don't go by dogmas. And if you want to improve, you have to have some kind of a drive. Yeah.
Yeah, but I think the next person is so.
Okay, and any tips regarding how to maintain a good database? We just have about 2 minutes more because, sir, we started at 9:15. Yeah, sir, please.
What Dr. Shastry has said is it's very important to have a very good database. So if you are going to do retrospective studies, and there are lots of hospitals, as I said, I was looking at the abstracts of IASG for the last 5-6 years. Very good, excellent studies, especially on liver transplant and all. They had such wonderful database. Everything is, all the studies and all the particular excellent manuscripts, I'm sure all of them must have got published in very good journals, was based on those databases. And the most important thing, I'm sure most of the hospitals would be following that. If you see any good manuscript, it's always written a prospectively maintained retrospective database. So that is what will give you all the information, because if you just go and just ask somebody to write a case sheet and draw the information from that, actually JIPMER has got a very good database, but if you just go back and try to see 15 parameters you want to find out from that, you will find in some case sheet only 10 are there, some case sheet only 7 are there, some case sheet only 12 are there. So when you are doing a study from that, there will be deficiency, because if you want all the 15, you have 100 cases, only 15 have got this problem, this parameters mentioned, 85 don't have. So all the 85 are excluded.
Yeah.
So that is why it's extremely
I
important
also-
that we maintain a very good, the moment patient is done, that is what it means by that. Today or tomorrow, you should enter it into a database.
Yeah.
So you have all the information with the important, under the supervision of a consultant.
Yeah, thank you very much. And I personally feel, sir, the answer lies in perhaps digitization of clinical content.
Definitely,
Which is going to come.
Definitely.
It might
There's
take
no
maybe
doubt
5 years, 7 years. What the bottleneck is lack of kind of time and resources for the person to enter that data every day, every single day.
Yeah.
So if we can somehow address and make it easier to fill in the data there and then,
Then and then. That
Then-
is very important.
then and
Because you
then.
forget otherwise.
then it will become relevant, and I think the answer will lie in digitization of clinical content,
Yeah.
and that's about to come. I
One
think.
last comment on randomized controlled trials. Okay, as I said, one point I'll tell in favor of that, that many times I understand in practice, in corporate practice, it is not very easy to carry out that sort of trial. So many of the people are not doing. But wherever it is feasible and possible, if the trial is carried out, what I showed you, all those plenary presentations, they are in plenary, because I am on the SSAT program committee for the abdomen and small bowel and all that. So last time when I took part in the meeting, I saw that everybody votes everything for the highest level of evidence. So this is, I am saying, at the global level, and US is at the top of that. So that is what they do. So wherever is possible, you do. If you do 1 or 2 randomized controlled trials, and nowadays there are central ethical committees, you don't have to have an ethical committee in your hospital also. You just register with that and carry out the trial in a simplified manner, which is possible and feasible without causing any problem to the patients, even the paying patients. And once you are on that track, you can actually do many, many randomized controlled trials, which are usually lacking in this, and it usually happens only in the typical institutionalized centers.
I'm just going to make a comment on Dr. Bhojwani's comment of maintaining database. I know some of my colleagues outside have actually splurged on clinical secretaries who are trained to enter the data into a database.
In fact, I have interest in this particular field, and I have myself kind of worked on some softwares and come up with content for our own unit. I worked on the app sheet on Google, and now I am trying to, with my own some colleagues, we are trying to make it a much wider and a better applicable manner, and hopefully it might take some 6 months to 1 year, and maybe for one operation to begin with, but it might so happen that next year all of such data would be entered by the resident or the consultant through their mobile in real time, there and then,
Just one
with
comment
just
if I can
clickable
make.
contents.
Yeah, the clinical database I had made almost 15 years back from simple Microsoft Access, and which over the next 5 years has progressed into a very robust database which is still followed in NIMS. The main problem with the commercial packages is they are too exhaustive. Too exhaustive. Say for an occupation you have 10 parameters, which is very rarely you even, so it's important to have an idea of which field is really important and constantly keep editing your software, which fields are maximum used, which fields are not used at all. And unless you do that, the non-compliance will be the order. People will not. People think it's easier to write than go through an exhaustive database.
So the answer lies in drop-down lists and clickables.
No, even
not
in a
writing.
drop-down list, if
You
you
don't
have
have to
a
write
10
A, B, or C. You just have to dot.
I understand.
That's it.
Even in a drop-down list, if you have 10 parameters, it's difficult. It takes long time to go through that and decide on which is appropriate.
Yeah, so it has to be conducive.
It has to be that. Yeah, it has to be. That is a very important part, and the clinician who also has some exposure to database has to sit with the software person and decide. Not the software person alone will never be able to do this.
Yeah, was last point to add on that it should not be too short also. Otherwise, what will happen is today I think I need only 10 parameters. But from 10 years later, if I need those 25, 15 extra and they are not there in retrospective database, then you cannot do the study. So it has to be balanced, not too complicated.
I think we've overstepped the time a bit, so perhaps this is a sort of conversation that can go on and on. But I really wish we had this in a plenary session, because I mean, every surgeon practicing and postgraduates have such a lot to take away from you both. Thank you very much.